Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford and I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respects to elders past, present and emerging. This webinar will focus on fear of recurrence for women with ovarian cancer, and it will provide an overview of the IConquerFear program, an online program to help women affected by ovarian cancer manage their concerns about fear of cancer recurrence and/or progression. We're extremely grateful for the funding received from AstraZeneca for this webinar. The webinar is interactive, so over the next hour you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. For technical assistance during this webinar, please phone Redback Support on 1800 733 416. So I'm privileged to introduce our speakers to you. Our first speaker is Associate Professor Lisa Beatty, an Associate Professor in Clinical Psychology at Flinders University and a visiting consulting clinical psychologist at the Flinders Centre for Innovation in Cancer. Lisa will provide an overview of fear of recurrence and discuss some strategies to help manage it. Our second speaker is Dr. Ben Smith, who is leading a team collaborating with OCA to trial IConquerFear. Ben will outline how IConquerFear may help people get less caught up with worries about cancer coming back or progressing, and some of the benefits that the program has shown to date. We will then hear from Victoria Turner, who was diagnosed with stage 3C high-grade serous ovarian cancer in 2020. Victoria will share her personal experience when it comes to fear of recurrence and will talk about how she copes and manages this fear. So I'd now like to hand over to Associate Professor Lisa Beatty. Thank you, Lisa.
Thank you. Okay, I'm really pleased to be invited to present today on fear of recurrence. I guess my role today is to just give a really broad overview of what it is and how it might present in clinic. Okay, so just to get started with, I thought I'd start with the established definition of what fear of cancer recurrence is. And it was defined by LaBelle and colleagues back in 2016 following a big consensus piece of work that they did as the fear, worry or concern relating to the possibility that cancer will come back or progress. Now, why is it a problem? A lot of people might think, well, everyone who's gone through cancer would be reasonably expected to experience fear of recurrence. And yeah, the stats do show that up to 73% of cancer survivors will have some degree of fear of cancer recurrence. However, I guess while it is a universally experienced concern to some degree and can have positive benefits in terms of potentially motivating some health behaviours, engaging in routine checks and recommended follow-ups, there can also be some real negatives in terms of being strongly associated with depression, anxiety, generalised anxiety. It can be chronic and disabling and increase healthcare costs as people may actually request additional healthcare visits and checks outside of what's routinely recommended. And I think perhaps most critically is that we know that it doesn't reduce without intervention for those who are experiencing really significant fear of cancer recurrence. Some of the early reports that first came out indicated that 49% reported what would be considered moderate to high fear of cancer recurrence. And these are the people who are at higher risk of these negative outcomes. So in terms of some of the research that's looked at categorising fear of recurrence, some of the measures that are one of the most commonly utilised measures is called the Fear of Cancer Recurrence Inventory. And when you look at the severity scale of this, there are different cutoffs that have been developed over time. One of the first cutoffs that was developed was a cutoff of 13 plus. And that's sort of more of an indicator or an initial screen that suggests that people may be at risk of fear of recurrence. And as you can see from this graph, this is the bottom line here. Would show that nearly 60% of people would screen as being potentially at risk for having fear of recurrence. However, two other cutoffs have been proposed of 16 and 22, and perhaps more recently the score of 22 or above on the fear of cancer recurrence inventory is really showing to be quite sensitive and specific to more that clinical level of debilitating concerns of clinical fear of cancer recurrence. And that shows that it's quite close to around 20%. So 1 in 5 people after they've been diagnosed with cancer will experience these really quite challenging and significant levels of fear. And this data has come from a big meta-analysis of 46 studies of over 11,000 participants from around the world, and also shows that the people who are potentially most at risk of experiencing this fear are younger people and also women. So I guess one of the key things then is, what do we mean when we're talking about clinical fear of cancer recurrence? Well, in the original definition and work that was done by LaBelle and colleagues, there were 5 key features that were proposed that would really characterise what would be kind of differentiate what's more normal or what everyone experiences in terms of some passing fears and ideas of the cancer may be coming back, from more what we mean by this debilitating or really impactful clinical fear of recurrence. The first of these is that there would be high levels of really preoccupation or worry and rumination or intrusive thoughts. So things that having thoughts and images and memories and ideas about the cancer that just can't easily turn out of someone's mind. This is then accompanied by some maladaptive coping strategies, and that would include things like the tendency to avoid reminders or avoid thinking about or avoid engaging in behaviours such as your checkups and things, or also in things like engaging in a lot of reassurance seeking, so feeling quite concerned about the cancer coming back and then actually going and asking for a lot of reassurance from family or friends or additional health checks, like additional appointments, to get that reassurance that the cancer hasn't come back. And one of the key things that can sometimes come up is this body checking, the idea that if I scan my body, I might pick up on the cancer at the first possible sign of it recurring. But the more we check and the more we poke and prod, the more likely it is that there might be some quite benign symptoms there that are then interpreted as being a sign of the cancer coming back. The third category or key feature of this clinical fear of recurrence is around functional impairments. So we're not talking, I think as what I started out by saying, everyone might experience some of these fears from time to time, but when these fears are getting to the point where they're causing interference in your ability to do your day-to-day activities, so it's impacting your ability to do your work, it might be impacting on some of your relationships, that's when we'd be saying it's starting to have a little bit more at that clinical end of things. And it may also be that it's causing excessive distress. So even if you're able to still go to work and do your day-to-day activities, but you're finding it's causing really significant distress and disruption for you, and you're finding it's really affecting your joy for life, that's another sign. And one of the last key features in this original definition was around the idea that it was difficult to make plans for the future, that some people might find that they're just not really seeing the point in making plans for the future because the cancer is going to come back and disrupt it anyway. So they feel quite paralysed about making plans for the future. Now, in 2020, there was an international study that provided a little bit of an update to these features, and really it was more about fleshing out the first of those, first and second categories of the original one, in terms of saying that it really is characterised by those high levels of preoccupation, that it's dominating thinking and really causing high levels of worry. And this needs to be persistent. It can't just be something that comes and goes or is fleeting. It needs to be persistently there for over 3 months. And that hypervigilance, that real awareness and constant scanning and checking of body symptoms is one of the key factors that we'd be expecting to see. So I guess that's all good and well to hear about it in terms of a checklist of things to look out for, but I thought I'd give a couple of case scenarios of what that might look like if you're in clinic or if you were presenting to clinic. So I've got 2 examples here. First of all, we have Jane. Jane is a 44-year-old married cisgender female with 2 daughters, ages 7 and 10, who was diagnosed with early-stage ovarian cancer 18 months ago. She stopped working as a childcare centre educator during her treatment and has not yet been able to return to work. Jane reports that she got through her medical treatment like a breeze, with everyone telling her how strong she was. However, since completing her chemotherapy 6 months ago, she's been finding it very difficult to get back to normal. Now, Jane presents as frequently tearful and agitated, and she states that she thinks she's going crazy as she can't stop thinking about her cancer coming back despite doing everything she can to put it out of her mind, including not using the term or the word cancer. In fact, Jane requests that you please don't use the word cancer in your sessions with her as she finds it confronting. Jane avoids reminders of cancer where possible, including changing the route that she drives to avoid passing the hospital where she had her treatment. She avoids cancer-related adverts on television. She avoids talking about her cancer with her family and friends. Yet despite all of these efforts, Jane knows that she still just can't stop thinking about the possibility her cancer will return, stating that she wouldn't cope and fearing how would the girls cope and that she'll leave them motherless. Jane is extremely sure, very, very sure that her cancer will come back and estimates that the probability of it coming back is about 90%. And that should be noted that even though that would not necessarily be the rating or the realistic probability that her oncologist or her treating team would be giving in the same, based on her active stage of cancer. And that she also believes that her stress or her worry may actually cause the recurrence, or at least make it more likely or more severe. Jane tries to minimise her risk by attending all of her scheduled appointments, and she also presents promptly to her GP at the first signs of bloating, pain or heightened fatigue. So this may look like someone you know. You may have experienced this yourself. This is kind of a combination of people that I've worked with that I've put together here, and some of the key things that we'd be looking out for as a psychologist. It hasn't really come up as well in this, but I've tried to highlight some of the things that really we're looking for here in terms of, the impact that it's having. We can see that she hasn't returned to work, even perhaps though she may have actually been cleared by her oncologist to do so. So this is actually more her worry and her concern around the fear of recurrence that's really impacting on her ability to return to work. It's been quite enduring in terms of it's been lasting for 6 months. And it's causing significant distress in terms of causing tearfulness, agitation. The worry is really, quite preoccupying for her and severe in terms of feeling like she's going crazy with it and not able to put it out of her mind. She's also using a lot of avoidance strategies here, and we can see that although in the short term they may help to her to not think about the cancer, it's actually keeping her stuck in this. The more you try and not think about something, the more it kind of demands attention. So there is a lot of, paradoxically, the more that she's avoiding in terms of even the places that she drives is actually in turn feeding back in and feeding that anxiety for her. And as you can also see, there is actually some signs there that she's doing some body checking and potentially also engaging in more healthcare service use than would necessarily be recommended by presenting to her GP really frequently. So that's one example where perhaps you're seeing a little bit more of the avoidance side of things, and also combined with a lot of the body checking. What would be another example? Well, this time we've got Josie, and she is a 69-year-old widow who was diagnosed with stage 2A ovarian cancer in 2019. She completed all her treatments in 2020, including a hysterectomy and a bilateral salpingo-oophorectomy and chemoradiotherapy. Now, the treatment caused a lot of side effects, including nausea and reduced appetite, along with severe fatigue. Josie's daughter, Maria, attended all of her appointments with her, as Josie doesn't drive and she lives alone. Now, Maria actually attends the appointment with you, the psychologist as well, and notes that since completing the treatment 2.5 years ago, Josie has talked constantly to me about when it will come back, and that Maria tries to provide reassurance, saying that of course it won't come back, that they got it all, but Maria knows that this reassurance doesn't seem to help all that much as Josie continues to worry, and if anything, she's worrying more with the passage of time. Josie's getting to the point now that she's quite concerned that Maria, her daughter, is getting fed up with her. She also says to you that she's aware that she's now halfway through her magical 5-year survival mark, and if anything, instead of viewing this as a good thing, she's now thinking it's actually more like she's into the latter 2.5 years and it's a countdown timer for her. So again, viewing it more as an inevitability that it will come back within that 5-year window. Josie has reduced her activity since her cancer diagnosis and is no longer volunteering at Meals on Wheels, as she wouldn't want to cause any disruption to the rostering team when her cancer comes back. Josie finds that her routine checkups extremely distressing and experiences what we often call, and she was calling, scanxiety each time. Josie thinks that if she keeps focusing on what she'll do if her cancer comes back and keeps talking it through, then she'll be prepared for it. However, Maria thinks that this might actually be impacting Josie's quality of life. So we can see from this example, and again, I've tried to highlight here, but the colours haven't quite shown up. I guess some of a slightly different presentation where instead of trying to avoid talking or thinking about it, we've got someone who's trying to cope by talking about it and thinking about it constantly and thinking that that will help them prepare and get ahead of it in some ways. But conversely, interestingly, this strategy, although it's the opposite to what Jane was doing, also actually keeps feeding into that, that cycle of anxiety, because the more you think and talk about it, you just can't carve out any time away from the cancer. Again, you can see that it's been quite enduring in this case. And it also shows that why for some people, the passage of time doesn't actually help. That if anything, it can almost feed into that, that fear of recurrence, because it is that countdown time mentality. We can also see it's having an impact in terms of her ability to engage in her normal activities as she's no longer volunteering. And I think it's also worth noting that for someone like Josie, we would also be wanting to factor in the isolation, the fact that she is widowed and living alone, and that might actually be increasing her vulnerability and her likelihood and her risk of actually experiencing this quite significant fear. So there's just two little examples, I guess, and these are drawn from people that I have worked with over time, you know, a combination of people, to really highlight, you know, some of the things that people talk through and how it looks in real life with people that we're working with. And I guess in terms of how we go about then treating this, there are a number of evidence-based therapies that have been developed, and of those, cognitive behaviour therapy does have the strongest evidence base. And recent systematic reviews show that psychological therapies that focus more on the process of thinking are actually more effective than what we're thinking. And what I mean by that is, instead of challenging the content of a thought, so for example, Josie's thought of there's no point in volunteering, instead, contemporary therapies will teach skills in recognising that you've been caught up in that story again, that you've been caught up in rumination, in that tendency to just think and unable to stop thinking about it. And then in turn to learn strategies about how to unhook yourself and pay those thoughts less attention. They're allowed to be there in the background, but they don't need to be the thing that you keep focusing in on. Combined with some behavioural strategies to reduce some of that reassurance seeking or to challenge that avoidance and body checking to levels that would be more commensurate with what medical professionals would be recommending. But you'll be hearing more about those particular treatment strategies in the next talk with Ben. Now, these treatments that have been developed over time can be delivered in different formats. Some of them have been delivered in individual therapy, and that's probably where the majority of the work that I've done has been in terms of delivering one-on-one therapy. Some other studies have also looked at delivering these sorts of programs in groups, and you can imagine the benefits there that you're hearing about how other people might be coping as well, and when one person experiences success, it can be really powerful to hear about that from other people who are going through it as well. But the challenge, I guess, of both individual and group therapies are that they're quite resource intensive to deliver, requiring a really specialised workforce that's been upskilled specifically to do that. And that workforce can be, we just don't have that many of them. So it's a small workforce and there's a really large demand. So I know that more recently we've been looking at online modalities for delivering and scaling up these sorts of programs. And I think one of the more recent pushes as well has been to look at what we call blended therapy, where it's a combination of potentially individual therapy with some online components as well. So there's some of the different options out there. Now, just a quick note about the definition. I just wanted to note that, as we said, that the fear of cancer recurrence as defined also includes, in the last two words there, progression. And everything we've talked about so far have been about people who've been treated with perhaps an earlier stage cancer where we're much more focused on it recurring. But what about for people who potentially have a more advanced disease or potentially metastatic disease. Or then there's the term fear of progression. Now, the exact wording of the definition originally was debated and chosen carefully to encompass fear of progression, to reflect the fact that they were viewed as identical constructs. However, at the time, it was recognised that additional research was needed to examine how the phenomenon of fear of recurrence might differ for those who have a curable disease with a fear of recurrence versus those who have incurable disease and are living with a fear of progression of their illness. And indeed, since then, some of the research has come out that shows that although they're very much related, there are actually different predictors and different factors that load onto these constructs. So they are actually quite distinct, very much related, as I said, but quite distinct. And so with that in mind, it is necessary to ensure that in clinical practice and research that these constructs are actually considered separately. Now, I guess one of the good things to note, though, is that the same kinds of interventions are demonstrating some promise looking at and treating fear of progression as well as fear of recurrence. And in Australia, where there have been some stepped care or programs for those who have responded to immunotherapy. There's been some online booklets that have been developed. There's been nurse-led interventions that have been trialled as well. And these are all pilot studies that, and they're all demonstrating that there might actually be some real promise for programs based on that contemporary style cognitive behaviour therapy in really helping with fear of progression as well as fear of recurrence. But the challenge is, as we've already said, that these programs, when they're delivered via the specialist psycho-oncology workforce, is that there's just not many of us. So we need to develop brief interventions that are scalable to try and help manage the demand to support both fear of recurrence and fear of progression. And the internet-delivered approaches would be an obvious first step. So I'm going to leave it there because I think that's a nice way to segue into Ben's talk. But if anyone has any questions, I think that's me done.
Thank you so much, Lisa, for all that valuable information. We do just have a couple of questions that have come up. One of the goals you listed for Josie was to help her reduce how often she seeks reassurance. Why is that?
Yeah, so as I kind of hinted at, we actually know it's one of those things that might sound a little bit paradoxical that, you know, by getting reassurance, you'd think that would make someone feel better. But I think most of us can also relate at times, whether it's about fear of recurrence or anything that's making us feel anxious. When you ask for reassurance, yeah, it does help in the short term, but actually all it ends up doing is keeping your mind focused on the very thing that you're anxious about. So yeah, it might help in the short term, but it actually ends up just perpetuating it in the long term.
Fantastic. Thank you so much. We'll leave it there. Thank you so much again for your time, Lisa. Really appreciate it.
No worries. Thank you.
So now I would like to bring to the microphone our second speaker, Dr. Ben Smith. Thanks, Ben.
Thanks, Vanessa, and thanks very much for the opportunity to talk to you all today, and thanks everyone for joining online at what can be a tricky time, particularly for those with kids. Hopefully you don't hear my two running around in the background too much. But today I'm going to be talking to you about how we can use online programs like one that we're currently working with OCA to evaluate, called IConquerFear, to increase the accessibility of treatment for fear of cancer recurrence or progression, which, as Lisa highlighted, is such a common problem. As Lisa's done a great job of outlining, we know that fear of recurrence is incredibly prevalent, particularly in populations such as women affected by ovarian cancer. We've got about 60% of cancer survivors generally who are experiencing either moderate or severe fear of recurrence, which is causing significant distress and impact on day-to-day functioning. But I'm not going to be talking too much, I guess, about describing fear of recurrence or progression, which I think Lisa's done an excellent job of. I'm really talking about how do we manage this issue, and I guess giving you some examples from the IConquerFear intervention that might be beneficial for you in terms of managing any concerns that you might have. The one thing I would like to note, just moving on from that last slide, is that we know this is really common in caregivers as well. So I don't know if there's any caregivers on the call, but this is, we know that it could, in some instances, it's even more prevalent in that group. And I guess the one thing that researchers showed is that actually, even though you might worry about burdening your caregiver with your own concerns and vice versa, it does actually help to air those concerns. And that idea of a burden shared is a burden halved certainly rings true in this case. So don't feel alone if you're experiencing these worries, and don't be afraid to share them would be two key messages to take away from that. So as Lisa alluded to, the good news is that there are actually some effective treatments for fear of recurrence or progression. One of them is IConquerFear, which was developed in Australia by the Psycho-Oncology Cooperative Research Group. It's a 5-session individual therapy delivered face-to-face by a psychologist or psychiatrist. And as Lisa alluded to, the goal of this therapy is really not to eliminate these thoughts or concerns, because we know that to a degree they are highly rational fears. But the goal of this treatment is to really, I guess, give people, help them to develop or figure out what's important to them after cancer, and develop goals to give their life purpose, meaning, and direction, and then to equip people with strategies that help them to assign less importance or attention to their concerns about recurrence. So to live well with those concerns kind of more in the background. But in a big trial where IConquerFear was compared to relaxation training that was matched in terms of the number of sessions and the time with the therapist, what was shown was that IConquerFear, even though both groups, fear of cancer recurrence, improved over time, the gains were particularly large in the IConquerFear group, and were maintained and even increased out to six months post-treatment. The problem is, unless you're lucky enough to have access to one of the fantastic therapists like Lisa, who is a specialist and is highly trained in delivering these kind of therapies, there's just not enough of those specialists to meet the huge demand that Lisa mentioned. So OCA's recognised this issue and has tried to, I guess, use the online medium to make getting help for fear of recurrence or progression more accessible. And so the first thing that they did was to develop this fear of cancer recurrence booklet. And then subsequent to that, as I mentioned, we're currently working together to evaluate the IConquerFear program, which is more of a, which I'll explain more about in a second. But just to give you a bit of an overview of the Fear of Cancer Recurrence booklet or fact sheet, which is available to everybody here via the OCA website, you can see from the contents page what kind of things are included in this. It covers, what makes people worry, the kind of worries that people have. It touches on the impact on caregivers as well, and then aims to equip people with some kind of practical strategies that they can use. And in a study conducted by some colleagues at the University of Sydney, 50 women in collaboration with OCA evaluated the booklet, and 3/4 felt it was relevant to women with ovarian cancer. 2/3 felt it was moderately helpful for managing worries, and more than 90% would recommend it to other women in that situation. However, we didn't actually see any significant changes in fear of recurrence after a relatively short period of a week accessing the booklet. So it's the conclusion after this study was that this may be helpful for, women with less severe fear of recurrence, but that more intensive solutions might be required for women with ovarian cancer, in particular, who might tend to have more severe concerns. So, as I said, that's where this partnership has developed to refine and evaluate an online self-guided program that Lisa and I and other colleagues have been working on for several years, called IConquerFear, and you can see the homepage here. And I really just want to give you a brief, overview of what this intervention entails and some of the strategies that it contains. So this is what the dashboard looks like. The intervention contains 5 modules, which roughly map onto each of the 5 sessions in the face-to-face intervention. So there's a close match between what we know works from the face-to-face intervention and what's delivered in this online self-guided program. And it contains a lot of videos from both clinical experts and people with lived experience. This is Professor Jane Turner and Jill Stannard, who's one of the consumers who worked with us on the program. And the first, I've tried to highlight here why this program may be more beneficial than a more static resource like a booklet. The first module is really focused on helping people, establish what their values are in life, what they find important after cancer, and develop goals and actions to live a life that's consistent with those values. So there's a values clarification task where people sort through these values that you can see listed here into their most important and least important values. And then we step people through the process of, reflecting on those values, giving them feedback on whether the goals and actions that they're presenting. So if people, depending on what kind of responses people give in this program, you get tailored feedback specific for you that helps you decide whether those values and goals are particularly important to you and realistic for you to achieve. The second thing that, as Lisa mentioned, with more severe fear of recurrence or progression, it's typified by a really these intrusive and persistent worries, but also a real focus on physical sensations that people interpret as potential indicators that the cancer could be coming back. And to combat this, we deliver an exercise called attention training, which is a slightly bizarre exercise, to be honest. At first glance, it involves listening to an array of sounds and focusing in on particular sounds and then switching between sounds. And that you might be wondering, what's that got to do with recurrence or thoughts about recurrence or progression? But I guess, as Lisa alluded to, what this program is trying to do is to help people if you think of your thoughts as just different types of noise, we want people to be able to tune in to the important thoughts and give less attention to that background or annoying noise. A bit like if you might be at a concert and you want to listen more to the guitar versus the vocals or something like that. And the goal here is to stop people from being so self-focused on these inner thoughts and sensations and more externally focused on interacting with the environment and people around them. So, and we provide graphs that each time people do this exercise, they rate how they're doing, and we can help people track their progress over time. Another strategy, which, I mean, you can all do at home, is, if you want, there are plenty of examples of this on the internet if you want to look them up. But of course, I'd encourage you to join IConquerFear if it's of interest, is Detached Mindfulness. This is a bit different to some forms of mindfulness you might be familiar with, in that it doesn't involve meditation or focus on the breath, and you don't need to practice it every day necessarily. But the idea behind this is to help people realize that their thoughts are just that, thoughts. That don't have to be engaged with. They can be treated like clouds passing by in the sky, or perhaps like, trains passing you by at a station, which are going to destinations you don't want to go. You don't have to hop on. And it's really to give people this appreciation that they don't have to get caught up in these thoughts, and help to train them to stop them from doing that. Another real pragmatic strategy that's included in IConquerFear is something called worry postponement, that some of you may be familiar with. And again, this is something that I guess can often be really revealing for people, because it shows that you can put aside your worries, and it doesn't, because one of the things that are thought to, I guess, play a key role in the development and maintenance of fear of recurrence or progression is these beliefs that worry can either be quite negative, in that if you worry too much, you might even cause your cancer to come back, or you might have positive beliefs around, if I worry a lot, I'll be really prepared. And exercises like worry postponement make people realize that, I guess, that there is really that the consequences of worry are not inevitable. So you can, it encourages people to, if they start having thoughts about the recurrence coming back, to just recognize that, say, I can see I'm getting worried about this, putting it aside and saying, I'll deal with it later. And then literally putting aside, 10-minute, you can write them down if you want, but then trying to focus again on whatever activity thing you are engaged with, and then putting aside 10 minutes at the end of the day, preferably not too close to bed, where you can worry about or focus on those worries if you really want. But what happens in a lot of cases is that people come to that time and they're like, I'm kind of, that's not so much of a concern for me right now, and they realize they don't have to worry, and that they have been able to keep going all day without that worry being a big issue for them. The IConquerFear also contains, I guess, some tips or strategies to help people find that balance that Lisa alluded to, between finding that not being constantly focusing on physical symptoms. Obviously, that's a real concern for women affected by ovarian cancer, but I guess there are some strategies like just thinking about whether this is a symptom you've had before, whether there's some other explanation for it, and just deciding on a period of time, which might just be 24 hours, to sit with that, and then perhaps calling the OCA helpline if it's still an issue, for instance. And there's also, I guess, some, women living with ovarian cancer are dealing with a lot of uncertainty. So there's some tips on things like healthy eating and physical activity, which are not only beneficial in terms of, I guess, your well-being when you're living with cancer or beyond cancer, but also can help you regain some sense of control after cancer. And ultimately, what the intervention hopes to deliver is a kind of a new way of addressing these concerns when they do come up. So what do we know whether this actually helps? So we've done a previous study in breast cancer survivors, and we know what we saw. It's a bit hard to see here, but was that there was relatively high levels of usage of IConquerFear, and you can see here some of the feedback that we received from women, which was generally really positive. And what we did see is that there was only one group in this study, but there was just what we saw is in the women who used IConquerFear, there was a reduction in fear of cancer recurrence, both immediately after they'd finished using it, 10 weeks, and then further 3 months later at 22 weeks. And what we perhaps unsurprisingly saw was a suggestion that those who used the intervention more derived more benefit. And perhaps more surprisingly, it tended to be older women who used the intervention most, which was really pleasing because it made me feel that we'd, I guess, delivered it in a way that made it quite accessible to everybody. And it was also shown that people with more moderate levels of fear of recurrence were perhaps those that used it most. Those with more, like the highest levels of fear of recurrence or progression may not be best suited to that. Might be, perhaps that face-to-face therapy is more useful in that context. So is it useful for women affected by ovarian cancer? Well, that's the question we're aiming to address in the study that's ongoing. Is this both a safe and acceptable and potentially effective tool for women with ovarian cancer to manage their fears of recurrence or progression? So if you're interested in taking part, we're looking for women who are diagnosed with stage 1 to 3 ovarian cancer and who have completed their hospital-based treatment, but if you're on maintenance therapy, you're still eligible. The website's only available in English presently, so you need to be able to be proficient in English, and obviously be an online intervention, you need internet and email access. Just to give you an outline of how the study works, this is what's called a randomized study. So there's a short screening measure or questionnaire you complete at the start, just to make sure it's suitable for you. It's not really designed for people who have really serious other mental health concerns like depression. So if you report that in the initial screening, you'll just be offered crisis information and further support from the OCA team. But then if you're not in that category, then basically we flip a coin, or like a computer flips a coin, to be honest, and you're then based on the outcome of that coin toss, you're allocated to either get immediate access to IConquerFear plus that Ovarian Cancer Australia FCR fact sheet that I mentioned before, or if you're in this what's called a waitlist group, you just get immediate access to the fact sheet. And then after 8 weeks, that group gets access. Both groups complete an assessment, and the waitlist group gets access to IConquerFear. So all participants ultimately get access to IConquerFear, but randomly allocating people to groups is the best way for us to be sure that any effects that we see at the end of the study are due to IConquerFear and not just to other random variation among the participants in the study. So if you are interested in taking part, what's involved? Well, there's no kind of set time that you have to spend using IConquerFear. We encourage people to spend about an hour a week for about 8 weeks. There's a few questionnaires to complete, which take about 10 to 15 minutes immediately or before, immediately after, and 3 months after using IConquerFear. And then there's some very short surveys at the end of each module just to get your impressions of the content in that module. And then there's also the option to participate in an interview to gain a more in-depth summary of your experience. Who's behind it? So there's a lot of researchers, clinicians, and consumers from University of New South Wales, Sydney Uni, Flinders Medical Centre, or Flinders Uni, as well as Ovarian Cancer Australia. So it's a really multidisciplinary and strong team. And if you want to take part, I'd encourage you can either go directly to the website. If you've got a phone, you can just use it to scan that QR code there. And I'll just stop there in case anyone does want to does want to scan that code, but happy to take questions if anybody has them.
Thank you so much, Ben, for that valuable presentation, and what a valuable program it is. So thanks for providing that overview. I do have one question. If my partner is worried too, is there anything like IConquerFear that might be able to help them?
Yeah, so as I said, fear of recurrence or progression is really common in caregivers as well. And we haven't designed IConquerFear specifically for caregivers, but we do encourage people to work through it with a loved one if they so desire. And as mentioned, or as I mentioned briefly, the OCA fact sheet does also have a specific section for caregivers. But I guess the key thing, as I mentioned at the start of my presentation, is it's really, I know it's not an easy conversation to have necessarily, but to share your concerns with those closest to you certainly seems to alleviate the concerns for both parties.
Thank you. And just one more question. I know this is what someone has written. I know this is just feeding into my fear of recurrence, but how important is it to get second and third opinions when it comes to treatments such as chemo?
Yeah, I mean, I think that's, as Lisa kind of alluded to, it's a bit of a fine line between seeking reassurance and the kind of feedback effect that can have on fear of recurrence or progression. But I certainly think there's no harm in getting a second opinion. But I guess I'm not a medical practitioner, so certainly something that you should discuss with your existing clinician, but I don't think many of them would discourage that necessarily.
Thank you, Ben. We also just had one comment come up just as Lisa finished, so hopefully Lisa's still online and I can put this to her. Someone's written, I've experienced a recurrence 2.5 years after first diagnosis. Nothing showed up in regular blood tests and screening. I had very slight discomfort. I pursued the screening and eventually a tumour the size of a mandarin was discovered. I was commended for pursuing it. I'm not particularly stressed, but very aware of checking regularly. So I kind of think that pursuing it saved the day. Lisa, did you just want to comment on that, please?
Yeah, for sure. I think that's just another point to clarify, that we're certainly not recommending or advocating that people sit and ignore symptoms. It's just more about how to live with the worry that comes up while you're waiting to find out what happens with them, and also around making decisions around not jumping on every symptom the second it starts. So it's about, working out how long can you sit with a symptom to follow those medical recommendations, and then how do you manage the anxiety that comes up while you're actually waiting to see whether the symptom needs to be followed up or not. So it's finding that balancing act between not wanting to get every single symptom checked, because it can end up being a bit like a radar that's picking up a lot of white noise and not always picking up what we really need to focus on, but at the same time not sitting too long on symptoms. So it is finding kind of that balance between them. But as I say, the most important thing is around for these programs is around how to live with the anxiety that comes up while you're navigating those symptoms.
Thank you very much, Lisa, and thank you again, Ben, for presenting for us this evening. I know you've got 2 young kids there, so you better go off and get them to bed, but really appreciate your time. So we will move on. I'm just conscious of time. I'm just going to flick through the slides to our next presenter, which is Victoria Turner, who was diagnosed with stage 3C high-grade serous ovarian cancer in 2020. I'll hand it over to you, Victoria.
Thanks, Vanessa, for the introduction earlier, and thanks to Ovarian Cancer Australia for the opportunity to speak tonight. It's been wonderful to hear Lisa and Ben speak and hear about their important work in the fear of recurrence space. And I'd like to share now my insights into fear of recurrence from the lived experience. So just very briefly, in 2020, at 59 years of age, I was had spent 8 months of seeking medical advice regarding my increasing symptoms, and I was diagnosed with stage 3C high-grade serous ovarian cancer. And I had chemotherapy before and after debulking surgery, and I completed frontline treatment in December 2020. And I'm relieved my active treatment's finished, but I do have several ongoing health issues as a result. And today, by coincidence, actually the 8th of December was 2 years since I finished that chemo. And I had an appointment actually today with my medical oncologist. And I was anxious in the lead up to the appointment, as I'd been advised by the GP that my liver function tests, which are normally good, had changed significantly. And the appointment and any tests or scan understandably trigger my fear of recurrence. I'm having an ultrasound tomorrow, and I'll have the usual anxiety awaiting the results. Also in my work, I'm a presenter and facilitator with ANZGOG's Survivors Teaching Students program, and in that I'm regularly reminded of the current ovarian cancer statistics, and both Lisa and Ben mentioned that as well. Stage 3C has a 70 to 90% recurrence rate and a 5-year survival of 39%. So understandably, I, and probably like many of people possibly on the webinar tonight, we ride the roller coaster of being vigilant for symptoms, but not letting our fear of recurrence dominate our thoughts. I don't have the BRCA1 or 2 gene mutation, so I'm not eligible for any PARP inhibitors or trials at this stage, and that causes me some anxiety at times, as I feel concerned that I have to wait for the cancer to recur to access other treatments. So while I stay vigilant, I understand the need to find balance and not jump at shadows. And so I'm just going to share with you a few things that have helped me live with ovarian cancer and maximise every day. I found the brain fog post-chemo quite overwhelming, and as a result of that and some fatigue, I didn't return to full-time work. But in September last year, I started back teaching nursing part-time online, and I even do some face-to-face classes now. And it's really sharpened my focus and given me back a sense of some control over my life. And although it's helped with the brain fog and sense of identity, I've noticed that I fatigue quickly and definitely feel less confident now than I did prior to the treatment. Obviously, that's why I'm nervous tonight. I'm enjoying more time with my husband, Stuart, and able to visit family, especially our beautiful grandchildren. And we were blessed with the birth of our 4th precious grandchild, Sebastian, on Monday this week. So that was very exciting. I'm currently participating in the Ovarian Cancer Australia sponsored exercise physiology program. I'm not sure if other people are aware of it. It's conducted via telehealth, and I have a Physi app, which is an application on my mobile phone that reminds me each day to complete the exercises. And Lauren, my EP, adds new exercises each week. And I'm really pleased to report that after only just a month, I've noticed several improvements in my balance and fitness, and because I've had quite painful ongoing neuropathy in my feet, and the exercises have really dramatically reduced my leg cramps, so that's a real positive. I had accessed an EP at my own expense over 12 months ago, but found they didn't take into account my specific issues, post-chemo and surgery, and basically the program that they set in a gym with weights actually caused me hip and back issues. This is a free program, the one I'm in with OCA, and they did a really comprehensive assessment and goal setting, and I feel I'm going to achieve my goals sooner. And OCA also offers free access to a dietitian, which I'm going to access in the new year, which will probably be very timely after the Christmas season. During treatment, I wasn't offered any support from a psychologist from my oncology team. I live on the far north coast of New South Wales, and I think, unfortunately, we as regional patients don't have much access to multidisciplinary teams like those that are offered at the metropolitan centres, places like Chris O'Brien Lifehouse in Sydney and Peter Mac in Melbourne. I did access a private oncology psychologist to help me deal with my fear of recurrence initially, but it was very expensive and I had to travel to face-to-face sessions during COVID. But I'd just like to tell you about a number of services that have been provided by OCA that I found invaluable. Firstly, luckily I heard about OCA's Teal support program whilst I was having my first lot of chemo, and I've got my own ovarian cancer nurse. So during active treatment, I'd be contacted by Fiona every week, and she provided amazing support. I could talk to her about anything, nausea during chemo, post-op pain, and she really helped me manage my fear of recurrence after the active treatment had finished. And even now, at the 2-year mark, she's still in contact with me. Every 6 weeks she checks in with me, and I know I can call her anytime if I needed her. I also, through the OCA Teal support program, have accessed free counselling sessions with a psychologist, and that was really helpful, and I learnt some meditation techniques as well as grounding and breathing exercises, and some of those Ben mentioned are also in the IConquerFear program. And speaking of the IConquerFear, I recently registered in it, and I think it's an excellent program. It's great that you can work through it at your own pace, as Ben mentioned. It's got wonderful videos and recordings that teach you strategies to cope with the fear of recurrence. And it also, as we saw in a slide that Ben had up there, it also helps you to set goals and monitor your progress. There's some really good printable resources, and one particularly that I liked was the guidelines for responding to new symptoms sensibly. And it was what was said earlier was sometimes, Lisa mentioned, sometimes needing to sit on a new symptom for a little while before, letting that fear of recurrence really take over. And I found the mindfulness techniques particularly helpful that were in IConquerFear. My most difficult times at night where I have intrusive thoughts about recurrence. So I actually used the Detached Mindfulness clouds exercise. Ben had one up on clouds and one on the train, and I really liked the clouds exercise to help me switch off. So I'd highly recommend that to anybody. And I've also attended some OCA support group online meetings, and some of them are general catch-ups, and some of them have topics such as Professor Claire Scott, she talked about clinical trials one time. There was one on advanced care planning and complementary therapies. So I also attend different webinars that I see come up. I went to a University of Sydney one about improving outcomes for patients with ovarian cancer, and it looked at lifestyle factors and survivorship. And I learned that the recent research supports that increasing physical activity contributes more to our survival than diet and reduction of alcohol. So that's good news for over Christmas. We can have a glass of wine guilt-free. And another important thing, they said that the ovarian cancer survivors with a stronger life purpose will survive longer too. And I've also enjoyed volunteering for some research projects. I participated in a QUT one about it compared massage versus heat pad for chemo-induced peripheral neuropathy, and I look forward to the outcomes of that. So lastly, I take time these days. Before I was busy working full time, and now I take the time to travel as often as we can and spend time with my amazingly supportive family and friends. So thank you for listening to my story, and I hope that sharing has been helpful to others, even if only to reassure you that the fear of recurrence is normal. We need to be vigilant, but we also need to have balance in our lives to allow us to experience all the joy that life has to offer. And I'd like to just finish with a brief quote from Mahatma Gandhi. Live as if you were to die tomorrow. Learn as if you were to live forever. Thanks, Vanessa.
Thank you very, very much, Victoria, for giving us an insight into your experience and some of the challenges that you face and how you manage them. I know everyone on the webinar really appreciates you being so open and honest and sharing your story, so thank you. We do have a couple of questions. One is, has your fear of recurrence lessened, or is it the same since diagnosis?
It's pretty complex, in fact. in some ways, the longer after treatment you don't have a recurrence, then the less fear I feel. But then another part of me thinks that about the statistics, and a bit like in one of Lisa's scenarios, that's saying the lady was worried about the 5-year survival rate, and so she was 2.5 years into it, and so I think it's a bit of both. But I go back to what I said before, I suppose, is being vigilant, but not letting it, overtake my life.
Thank you. And one more. We do have a few questions, but I do apologise if we don't get to your question. Do you find support groups helpful?
Yeah, I personally do belong to the Facebook one, the Aussie and Kiwi support group. I know some women with ovarian cancer that told me they don't like them. They don't like hearing when someone has a recurrence or when, sadly, somebody passes away. But I find them a good source of reassurance, and I find that they're often a source of new information, which I can follow up with my medical team, or that they make a reference to a book or a talk coming up, and I can access that. So I find them helpful, but I can understand why they're not for everyone.
Thank you, Victoria. Thank you so much again for joining us this evening and for being so open and honest and sharing your story. We really, really appreciate it. There is one more question that I'll be able to answer. Someone has written, I love the sound of the exercise program and access to a dietitian. How do I go about getting involved in the program? I'm actually the program manager for that program. So there's a couple of ways. You can either call our information and support line, so 1300 660 334. And then they'll put you on to myself, and I'll be able to start the process and enrol you into the program. Or else you can email exercise nutrition, or one word, at ovariancancer.net.au. It is definitely a great, it's a valuable program. So we will leave it there. I'm just conscious of time. I'd like to just say a big thank you again to all our presenters, Dr. Ben Smith, Associate Professor Lisa Beatty, and Victoria Turner. We really appreciate giving up your time this evening and sharing so much valuable information. I'd like to thank everyone for being on this webinar. We really hope that you did find it valuable. The recording of this webinar will be posted on our website in the next couple of weeks, and you will receive an email with a link to the recording in the next few days. In a moment, you'll be directed to an evaluation form. If you could just please take a moment to fill in that form. Your feedback is extremely important to us, and it does help us to plan future webinars. If you have any other questions that you would like addressed, or if you do require some support, please don't hesitate to contact our information and support line, 1300 660 334. Thanks again, everyone, for joining us on this webinar this evening. We wish you and your families a wonderful Christmas, and we hope to see you again on our next webinar in the new year. Good evening.